Well, good evening. We'll go ahead and get started. It's a little bit after 6:30. We're getting together for our monthly in-service talk tonight. We're going to talk, the primary topic is gastrointestinal bleeding, GI bleeding. What I want to do tonight is go back and review what we've talked about over the last couple of months, particularly as it relates to allergies with the season. I want to tell a little story. And we're going to talk then about gastrointestinal bleeding, as it's a real common problem that we encounter both in EMS and in hospitals. So if you remember back to last month's talk, we were talking about allergies and anaphylaxis and the common symptoms that are commonly occur with an allergic reaction. Itching, swelling, rash, almost 9 out of 10 people get those. Wheezing and shortness of breath are ominous signs, if you will, and about half the people get those. A third of people get dizzy and pass out. Some get nausea and GI symptoms as they have an allergic reaction, and soft tissues swell in the gut that causes abdominal discomfort and nausea. The flushing goes with the rash. The ominous one that we worry about is upper airway swelling, angioedema affecting the upper airway. And somewhere between 50 and 60% of people having an allergic reaction can have that. Many get runny nose. Not too many have seizures. So what are the common causes that we talk about of allergic reactions? Drugs are common culprits, particularly some antibiotics, some anti-inflammatory drugs. Peanuts have really become an issue in the last 10 years or so, but foods, peanuts, shellfish, eggs are all common offenders. This time of year, particularly at period when the trees and the flowers start blooming until sometime around Thanksgiving, the first frost, environmental allergens, pollen, is a problem, and many people in our part of the country have hay fever and what we call allergic rhinitis symptoms. Some folks have problems with soaps and lotions. A common question we ask when someone comes in with a diffuse rash is, have you switched laundry detergents? Have you used anything different? Some people have reactions to hair dyes or sunscreens or different things, and many times you can see that the rash they have fits a certain pattern. For instance, if their rash is only on sun-exposed skin and they're using sunscreen, you have to think that was part of the problem. Bee stings this time of year can be problematic, and as we talked, you can get stung 100 times, not have any problems, and the 101st you may have an allergic reaction. So Hymenoptera venom, that is bees, fire ants, wasps, for instance, are common offenders. And good evening. And it's not the snake bite, but it's the snake anti-venom that causes problems. The handouts are here on the front, Chief. But the snake anti-venom is somewhat problematic. And then, of course, the big thing that we've seen in the last 10 or 20 years are latex allergies from the rubber protein in gloves. And that's an allergy that's becoming more and more common in healthcare workers. You'll see folks who put on a set of gloves and they take them off, they have red skin fitting that pattern. And latex is so common in our society, and it can be a very mild reaction to a life-threatening reaction. So we talked about the 10 allergy pearls, things that you got to remember on allergic reactions. Hypoxia kills. So when people are having allergic reactions and we're treating them, we want to watch for the hypoxia. We treat with oxygen, we watch their oxygen saturations. We treat the shock. We want to treat ahead of the person developing what we consider classic symptoms of shock. We want to keep their blood pressure from dropping. We want to keep the tissues perfused. We have to recognize the limits of some of the things that we commonly use. For instance, Benadryl and steroids, as we talked, are delayed treatments. They work for that secondary reaction. They may not fix the acute problem. We've got to watch who's getting into trouble. We always watch that person who may say they're having swelling in their throat, or they can't talk, or they feel hoarse. That's somebody that might be getting into trouble with airway compromise. One of the pearls, it's a family affair. There is a tendency for certain allergies to run in families. Around the beta block, some patients who are on beta blockers for various causes will not respond as well to our usual therapies, such as an albuterol aerosol. Prevention's huge. If you know somebody who's had a significant allergic reaction, that person probably, if they've had a reaction where they got rash and they got wheezing and they really got sick and had to be treated, they probably need to be carrying an EpiPen and Benadryl with them, and they shouldn't be out walking through the clover in bare feet and so forth. Prevention is huge. And that leads to the ability to self-treat. Folks who've had bad allergic reactions need to have the ability to self-treat themselves with life-saving treatments. Allergies are acquired. As we said, you can take penicillins or various antibiotics and do well, and then all of a sudden one day you have an allergic reaction. And then be suspicious. Anytime someone is itching and they're wheezing, you've got to be concerned that they might be having an allergic reaction. So what do? Airway and breathing. We sit them upright. We get them on oxygen. We examine the mouth and the throat for swelling, for edema. As we talked, epinephrine is important early. We can give albuterol aerosols for wheezing, but the key is epinephrine. It's the cornerstone of treatment. It improves vascular tone. It improves contractility of the heart. It blocks some of the allergic mediators, and we give 0.3 to 0.5 milligrams IM. We can repeat it every 5 minutes, and giving epinephrine should not slow us down. That should be the first thing, and we shouldn't be trying to get IVs and so forth. We should get the epi first, then start doing our other treatment modalities, come back at 5 minutes and see if that epi needs given again, and if so, repeat it. It is the cornerstone of treatment. So tonight is kind of interesting. We're here on May the 26th, and it was 44 years ago today that I worked my first shift as an EMT in a little county in northern West Virginia, and that was effectively the start of my medical career. And you talk about everybody who is involved in fire, police, EMS, whatever, they've got somebody who kind of guided them there. And the fellow who guided me into medicine is a guy named Doug LaFosse, and he was one man who made a difference in a county in that he was the point, if you will, that got an EMS system started. And I don't know how many of you remember back in the 60s and 70s what EMS was. There really wasn't EMS. An ambulance was a station wagon that had a red light and a siren. It was one person who may or may not have had first aid training at best. And when you got sick, the ambulance showed up and put you on a cot and took you, usually at high speed, to the local hospital where you went to an emergency room, and it literally was an emergency room where there was a senior nurse, there was not a physician. Emergency medicine, as we know it today, didn't exist. There was no EMS. There was no emergency medicine. There weren't staffed emergency departments. And so in our county in northern West Virginia, that's exactly what it was like. And this one individual, Doug, really got the community together, got civic leaders together, and started in 1972 what was the Marion County Rescue Squad, which is now the EMS system of that county. And I, as an 18-year-old, was an EMT and got to work the very first shift of that. And that was where things started for me. And I got then pushed along to become a paramedic and an Army medic and a physician. And so Doug and I have remained friends for years. And I keep friends like him because I can beat him at golf, and there aren't many guys like that. So you got to keep those around. But it's kind of cool that here we are on May 26th. It's 44 years ago to the day when I first started as an EMT. And my first case as a brand new EMT, now we didn't have anybody, we had no experience, we hadn't ridden with anybody. In my first case, which came a couple days later, we had a 3-person crew. We went up 20 or 30 minutes into the country and found this 60-year-old guy who was pale and unresponsive and was incontinent. He had stooled himself and the odor was terrible. He was pale and sweaty and his heart rate was fast and I couldn't get a blood pressure and there were liquor bottles everywhere. And so we packed him up, took him to the VA hospital, which was 20 or 30 minutes away. And en route, I'm trying to process what's going on here. And you go back to the basics. Airway, yeah, he's breathing. He's got an open airway. He's breathing. Circulation, I need to get his feet up in the air. And we got him to the hospital, and it was probably 30 minutes later getting back before I finally figured out that, geez, this was shock. And geez, that guy probably was bleeding. Now, fortunately, in those 44 years, I've come to make decisions a little faster and figure things out a little faster. But I was doing this lecture, I thought, holy cow, it's the anniversary of when I started, and I'm doing a talk on GI bleeding, which was the very first case that I ever saw and didn't recognize. So when I say it's sometimes a tough diagnosis, it certainly was for an 18-year-old EMT with no experience. But it really is. GI bleeding can be tough because it's not readily apparent. Digested blood, and if you just get a teaspoon of blood in your stomach, you tend to get nauseated and throw back up. But digested blood, when it's expelled from the body, the patient might not recognize what the significance of that is, what the significance is of having dark stools for a couple of weeks and then all of a sudden feeling kind of weak. The other thing is that some things that come out bright red that look like blood aren't really blood. And the challenges for us as in emergency medicine are obviously dealing with chronic alcoholics because they are high risk for a lot of different things, and their social and their physiologic abnormalities really can blur the picture. But one of the things is the location of the bleeding usually is not apparent. We go through all these algorithms and studies, and many times someone goes into the GI bleed and they really don't know, when it's all said and done, what the point source of that bleeding was. Let's talk about some definitions, which are handout, because I might throw these words out and don't want to stumble through them. But cirrhosis of the liver is something that is not uncommon in GI bleeds. And cirrhosis of the liver is a chronic disease that is effectively scarring of the liver. It's destruction of the liver cells from a variety of causes, which then leads to scarring, and the liver doesn't work well and blood doesn't flow through it well. Endoscopy is looking in a body cavity with a scope, with a lighted scope. Definition of peptic ulcer is erosion of the lining of the esophagus, the stomach, or the duodenum, which is the first couple feet of the small bowels that comes out of the stomach. So a peptic ulcer means any ulcer in the esophagus, stomach, or the duodenum, usually caused by action by stomach acid, whereas a gastric ulcer is an ulcer in the stomach itself. Hemorrhoids are dilated veins in the perianal region. We're going to talk tonight about vomiting blood and passing blood. The technical term is hematemesis, heme, blood, emesis, throwing up, so vomiting blood. And melena is passing dark blood through the bowels. So when someone has a GI bleed, as you might expect, there is an event, and in many cases it's stopped or controlled, but there can be complications. And so the significant complications of GI bleeding is first and foremost rebleeding. They bleed once, they stop, then they cut loose again. Another complication is the need for surgical intervention to control bleeding. So someone's really, really bleeding, they found the source, and it could be either a bowel resection or a radiographic procedure where interventional radiology goes in and coils or do whatever they do to stop bleeding, cauterizing or sclerosing a vessel. But bottom line is some people need surgical or interventions to control the bleeding. If their hemoglobin, remember our hemoglobin for most of us is 12 to 15. If that hemoglobin gets under 7, that's usually an indication for transfusion. Transfusions carry their own set of complications. And then really the other ultimate complication is death. Kind of the ultimate complication. So when we talk about GI bleeding, when we talk about complications, we talk about patients either being low risk or high risk for complications. So a patient who has a GI bleed, if they have no liver disease, they're not on blood thinners, they're not previously anemic, they're under 60 years old, and like I said, every year that I get older, this age seems to seem less and less to me, but under 60 is the key. So no liver disease, no blood thinners, no anemia, age less than 60, stable vital signs, blood pressure over 100, they're really at low risk for complications from a GI bleed. But on the other hand, someone who's taking warfarin, Coumadin, someone who's had previous ulcer history, they're on steroids, they're diabetes, and that always complicates virtually any illness. If you're on steroids, you're diabetic, there are complications to be had. If someone's had a bleed and they talk about having indigestion frequently in the last year, there's probably a reason for that. Smoking complicates it. Non-steroidal anti-inflammatory drugs. When you see this, we're talking about Motrin, Naproxen, Aleve, that whole category of things that we all take for aches and pains. They're anti-inflammatories that have taken in large enough doses basically eat your stomach up. And aspirin use. Aspirin's a great drug, but also causes gastric irritation, and it stops platelets from working. So aspirin use is a risk factor. So the list continues. High risk for GI bleeding if they have pre-existing liver disease, if they passed out, so they're presenting, we've talked about syncope in our previous lectures, if their presenting symptom was they passed out and then they're having GI bleed, they're at risk for complications. Again, age over 60, change in mental status, low blood pressure, history of alcohol, overuse, and if they're laying still, so if they're at rest, particularly laying down, they're tachycardic, they're at high risk. And these are things that we got to watch for, and while we talk about this is why do we be concerned whether they're low risk or high risk? It really defines where we're going to take the patient. Someone who's low risk and has a single episode can probably be managed in the local hospital. They can get endoscopy, they're stable, but if they have a significant bleed and they have any of these high risk criteria, they are probably going to need some intervention. They're going to need gastroenterology. They're going to need it quick. They may need ICU management. And so when you talk about why be concerned, we're talking about where they go for treatment. And so they should go to a major center. For us, that, Duke, Regional, UNC, if older age, if they're in shock, if they've got coexisting diseases, and if they're on anticoagulants. And that really leads us to a good time to just review real quickly the types and causes of shock. We've had this lecture, but remember 4 types of shock: hypovolemic, distributive, cardiogenic, and obstructive. Tonight we're talking about the blood loss hypovolemic shock, if these patients are truly shocky. And remember, how do we diagnose shock? Earliest symptom many times is thirst. Our body's lost fluids. We sense that loss of fluids and decrease in our fluid volume as the first thing is thirst. People want something to drink. They may have subtle changes in mental status. Heart rate may pick up a little bit. Their normal resting heart rate's 70 or 80. Now it's 90 or 100. Remember, decreased blood pressure comes late. If you're waiting to diagnose shock by low blood pressure, you've missed the boat. So that narrow pulse pressure, so they might normally have a pressure of 130 over 80, and all of a sudden it's 110 over 90. That pulse pressure is narrowed down. Skin color, pale. If they're mottled, that's always a bad sign. So always look at the skin, always look at the lower extremities. Are they sweaty? Those are things that we start with. And just to review again then, cool clammy skin, pale cyanotic skin, decreased blood pressure, late sign, narrowed pulse pressure, altered mental status, decreased capillary refill, all are things that we use to diagnose shock. So back to GI bleeding. How often does it occur? It's fairly common. Talk about 40 to 150 cases per 100,000 people. So let's say that we say it's 100 cases per 100,000 people, so it's 1 case per 1,000. We got 40,000 people in this county, so we can get 40 or 50 cases of significant GI bleeding we would expect in our population a year. Upper GI bleeding is more common, increases with age, over 60, increases in men. And the mortality from GI bleeding is due really to age and coexisting illnesses. So the GI bleed's a problem, but it is the coexisting illnesses that get really involved that typically cause the mortality. So when we talk about GI bleeds, we talk about upper and lower. Upper GI bleed is bleeding that's coming from the esophagus, the stomach, and the first portion of the small bowel. And lower GI bleeding is everything else. So what are some causes? If we talk about upper GI bleeding, talking about peptic ulcer disease. Remember, peptic ulcer disease, ulceration, esophagus, stomach, bowel, esophageal varices, which are prominent collateral vessels in the esophagus, gastric ulcers, something called a Mallory-Weiss tear, which is a tear of the esophagus you can get from violent vomiting, and all of a sudden you get a tear in the esophagus and it bleeds. Catastrophic cause, aortoenteric fistula. Blood basically gets from the aorta into the esophagus. Never a good outcome with that. And then whenever there's GI bleeding, we always think of malignancy, whether it's upper or lower. So when we talk about vomiting blood, hematemesis, blood that is fresh from really up high is red. Partially digested blood is coffee ground-like. As soon as blood gets into the stomach, it starts getting worked on by the acid. It starts changing colors. And a teaspoon of blood in the stomach will cause you to be nauseous. So vomiting blood, bright red or coffee ground, suggests an upper GI source, but it's not always 100%. There can be other causes. If you have bowel obstruction, you can throw up blood from lower sources. There are a lot of causes of lower GI bleeding, which is less common, but we see a fair amount of. Diverticular disease, inflammation of the bowel, colitis, hemorrhoids. Of course, one of the causes we all worry about over 50 are malignancies, colorectal cancer, arterial venous malformations, and again, a fistula between the aorta and the bowel. So how does lower GI bleeding present? Well, it's typically blood in the stool, and that can be anything from small amounts to large amounts, but someone who's passing a real large amount of bright red blood indicates a lower active source of bleeding. And it can be as little as just a trace of blood on the stool or in the stool. But blood, again, that's been exposed to the digestive process is dark and may look pitch black. And if you've never had the pleasure of smelling it, GI bleeding, blood coming through the bowels, is a distinctive foul odor that you recognize in ERs very quickly when you walk in the room. One of the causes of upper GI bleeding that is life-threatening is that of esophageal varices. And this is typically associated with bad liver disease. The liver disease causes scarring of the liver, so typically cirrhosis. So the blood can't flow through the liver as it did, so there tends to be portal pressure rising. That causes veins to dilate, particular veins in the esophagus, around the rectum, hemorrhoidal tissues, and around the umbilicus. And so it's a classic triad. If you see somebody who's got bad external hemorrhoids and these prominent veins around their umbilicus, they may well have esophageal varices to go with it. Causes of cirrhosis, alcoholic liver disease is way up there, but the other is hepatitis, and that's the concern when we encounter these patients in the field, is if they're vomiting and we get a blood exposure, the question is their illness, do they have hepatitis? Esophageal varices carry a fairly high mortality. I mean, it can have a 20% mortality with an acute episode, so it's nothing to mess with. Peptic ulcer disease is erosion of the lining, the mucosa of the stomach and small bowel. And it's really the most common cause of upper GI bleeding. It's typically not life-threatening as is esophageal bleeding, but it certainly can be. But peptic ulcer disease is often related to bacteria, something called H. pylori. It's a bacteria that likes an acidic environment. And over the last 15, 20 years, it's been discovered that really it's uncommon to have ulcers in folks who don't have H. pylori. We can do a finger stick test in ERs and in our clinic, and positive or negative for H. pylori. Someone comes in with burning epigastric pain, you check it, it's positive, you got ulcer disease, and it's due to this bacteria, which then we treat with antibiotics. We eradicate the bacteria and treat the ulcer, and it gets better. But peptic ulcer disease is uncommon in folks without H. pylori unless they're taking non-steroidal anti-inflammatory drugs. So someone who's taking big doses of Motrin, they got arthritis or joint pain or whatever, and they're taking big doses 3 times a day, and they're taking on an empty stomach, end up getting gastritis, they end up with a GI bleed. This was the claim to fame of drugs like Vioxx and Celebrex, as they protected, they took care of the pain, but they didn't eat your stomach up. And of course, then they found out that they were causing heart problems and got taken off the market. So the choices are limited in what we can take now. But with peptic ulcer disease, if you don't have H. pylori, you got ulcers, then you're probably taking nonsteroidals, or you're probably a smoker, using alcohol, aspirin, age over 50. So H. pylori is the big one. This I've seen 3 cases of aortoenteric fistula in my 25, 30 years, whatever, since 1987. 2 in EMS, 1 in the hospital. And what happened, it's an uncommon cause, but it's a catastrophic cause. And one cause of this are patients with grafts in their aorta. So they, whatever reason, had something that required putting a graft in the aorta. And that's a foreign body in your body. And over time, it may cause an erosion or a scar between that area of grafting and the esophagus. And then all of a sudden, that scarring breaks down and you get a little leak, and it's under high pressure, then you get a big leak. The 3 cases I saw, 2 were in EMS, where we walked up on the porch literally to find someone slumped over and more blood than you could ever see, and they essentially exsanguinated right there in one massive episode of vomiting. The 3rd case was a young woman who fit this exactly. She had earlier some, and I forget what it was, some procedure with her aorta and had a graft. And she came in with the complaint that she had thrown up a fair amount of bright red blood. Her vital signs were normal. She looked normal. She was feeling fine. But given the history, it was elected to admit her to the hospital for observation, get GI, and so on and so forth. So we did just that. And she left the emergency department, and as they were moving her from the transfer stretcher to her bed in the step-down unit, she had another episode of vomiting and exsanguinated. And it is impressive. So what she had was what's called a Herald bleed. She'd had a small leak. She threw up. It kind of clotted off, but then it cut loose later, and that's not an uncommon presentation. So it's rare, but when you see it, it's impressive, and it's usually the last thing for them. So lower GI bleeding, lots of causes in the colon, but anything that can disrupt the mucosal lining of the colon can cause bleeding. And that can be something as simple as, and we talk about colitis, someone who's got recurrent diarrhea and the bowel gets irritated and then it starts bleeding. But patients get radiation colitis, get infections of the bowel. Obviously, we talk about malignancies, particularly of the descending colon, colorectal cancer. You get a mass, it starts bleeding. Arterial venous malformations, little AV malformations that let loose and start bleeding, or bleeding diverticula. So diverticula, we talked about in our abdominal pain lecture, are little outcroppings in the bowel. They get irritated, and when they do, they get infected, and it's called diverticulitis, but they can get basically dilated and stretched to where there's a little vessel in there that starts bleeding. And in medicine, it's called a bleeding tick, and that can be a cause of lower GI bleeding. So patients come in and they may be talking about a very small amount of blood, which is very alarming to them. They see blood in the toilet, or they see blood on the tissue paper. And if it's bright red, typically it's a low cause. When I say low, you start thinking of causes of GI bleeding, and you start thinking of the causes, you start right at the outside, at the rectum, and you start working your way up. So a cause of bright red bleeding in small amounts, the most common cause you're going to look for is an internal or an external hemorrhoid. People can have a hard, large bowel movement and get a little tear in the rectum, have a rectal fissure. That'll bleed. It's usually painful. There's a number of causes for rectal trauma. All can cause bright red bleeding. And then you start talking about larger amounts of blood with clots. Now you're talking about something a little higher in the rectum or the sigmoid, and depending on how fast it's bleeding, how much blood's coming out. Diverticular disease with a bleeding arteriole would come to mind. Any time that someone's passing dark, foul-smelling blood and stool, that can be anywhere from the small bowel south, and it really depends on the rate of bleeding, how fast it's coming out. If someone is having the urge to have a bowel movement every 30 or 40 minutes or every hour, and they do, it's dark stuff that smells bad, they're having a fairly active bleed, probably up high, that's transiting the bowel and turning black, but they're continuing to bleed. And these people are the ones that are dropping their hemoglobins, and they're going to get in trouble. So the blood that's dark can be anywhere along the course. What makes this difficult is there are a lot of things that mimic GI bleeding, both upper and lower. So you're talking about bright red blood coming out of your mouth. Well, that could be from a nosebleed. Back in the back of your nose is dripping down, you're spitting it out. It can be from a bleeding tooth or tonsil irritation. You'd be surprised how often people throw up red fruit punch and think that it's blood. And someone who's got bad diarrhea, you put something red in the mouth, red's going to come out the bottom. So, eating red food, Jell-O. When you go to have your colonoscopy, they say don't eat red Jell-O. You can eat any color but red. Things that cause dark stool and worry you. If you take Pepto-Bismol, you're going to get dark stool. And people will say, oh, geez, I had black bowel movements. Well, were they tarry? They smell? Does that look like blood in the stool, partially digested grapes, beets? People have bleeding. Women vaginal bleeding or bleeding from the urinary tract, and they get up and there's blood in the toilet. Many times you can't tell where it's coming from. Lesions and wounds on the buttocks can cause blood that they think is coming from the stool. So there are a lot of things that cause it. Eating red meat, when you do an occult stool test, so you put the stool in the card, you put the drop on it and see if it turns blue and see if there's blood in the stool. Well, eating red meat can cause that. Turnips, I didn't realize that. Horseradish, I didn't realize either. Excessive vitamin C can all cause false positive stool testing. So what do we do in the pre-hospital setting? We've talked about different causes of bleeding. We've talked about presentations, high risk, low risk. What are we going to do in the field? And it really comes down to three things. We're monitoring, close watch, oxygenation, and perfusion. We want to prevent shock. So one of the things we want to know, history, as we do on every patient. What medicines they taken. We really are focused, and if it's a crisis, you really want to know, hey, are you taking any blood thinners? And particularly, are you taking warfarin or Coumadin? A lot of people are taking aspirin. A lot of people are taking Plavix and things like that. We want to know if they're taking warfarin, Coumadin products. Or now some of the new ones like Xarelto. Have they had GI bleeds before? If they had a GI bleed before and having one now, we want to know that they have a history of ulcers. What other illnesses you have? We talked about that a few minutes ago, the coexisting or comorbid factors. And hey, over the last couple of weeks, you had indigestion, you had dark stools, anything like that. That's part of the basic history. Airway and breathing always first. The problem with GI bleeding is we can get airway compromise simply because they're vomiting. So we've got to have suction available. We want to get oxygen to all these people. If they're short of breath, CPAP's probably not a good idea. Putting that mask on, then they vomit. Now we have a potential airway compromise with that. So beware CPAP in the presence of vomiting for any reason. this is one case where if the patient needs intubated, using a blind airway device is probably better, because someone who is vomiting, there's a lot of blood, it's going to be very difficult to visualize the cords, and it may be best to suction them out and get a blind airway device in and get the airway stabilized as quickly as possible. Talk about circulation, IV access, large bore is better. These patients may get blood. We don't like to put blood through less than an 18 gauge ideally, so getting a large bore IV in. Fluid boluses repeated are indicated. We want to prevent shock, and remember what we're trying to do with restoring volume is preventing metabolic acidosis. We're trying to keep perfusion to the tissues. Interestingly, one of the things that is really interesting or really indicated is getting some treatment for the nausea, which requires getting an IV in place. But reducing the vomiting may well protect the airway. I mean, these folks who are getting blood in their gut, as soon as the blood gets in there, it causes nausea and they're going to throw up. And that can eventually certainly cause airway compromise. So it stands to reason they should get nothing by mouth. And we ought to have the emesis basins and the blue bags available, but getting them a dose of Zofran or Phenergan, if there are no other contraindications, is certainly indicated. Key for us as providers is not getting an exposure to an unwanted illness. We talked about someone who's having a big upper GI bleed. They certainly could have esophageal varices. They certainly, if they have a history of alcoholism, they could have liver disease. They could certainly have hepatitis. And so there's a high rate of hepatitis in association with esophageal varices, and we don't want that exposure. So anytime we're working with people and there's blood being spewed, in this case they're vomiting or they're coughing and it's being aerosolized, we want to make sure that we're taking prudent precautions. We've got glasses or goggles, we've got masks, we've got gloves, we do the usual stuff to protect ourselves. You know, what can complicate things? Someone has a GI bleed. Let's say they're 60 years old and they have previous history of coronary artery disease. So they lose blood, they rapidly get anemic, they lower their oxygen carrying capacity. So now all of a sudden they've got narrowed coronary arteries or cerebral vascular disease. They get chest pain, they get anginal pain, they get TIA or stroke symptoms. As we drop our oxygen carrying capacity and we get anemic, we get that sensation of shortness of breath. We don't have the capacity to get oxygen from the lungs to the tissues again. They drop your blood pressure and pass out. Syncope is basically not perfusing your brain for a brief period of time. So young, healthy people might tolerate a GI bleed and appear to be doing okay, but then they compensate, but then suddenly crash. And that's not uncommon either. So you see their heart rate coming up and their pulse pressure coming, and they seem to be doing okay, then all of a sudden they have another bleed and they go south real quick. So you've just got to be leery of that. So look for the early signs of shock. Look for that narrowed pulse pressure. Look for the tachycardia. Look for the changes in mental status. And those may be subtle. It's just someone who might be a little bit confused. As we talked before, looking at skin color. Hold your palm next to theirs. Look at the eye grounds. Look at it. Do they appear normal color? You know, if you don't know, look at your partner's eye grounds. Look at theirs. If they're dropping their hemoglobin, they're going to start getting pale, and that's the first places you can look. But normal vital signs don't eliminate the complications or decompensation or the threat of GI bleed. Don't get fooled if they're having GI bleeding at normal vitals that they're out of the woods. They're not. So what's prevention? And every time we do in these lectures, we talk about how do we prevent this illness. Well, for those of us who are over 50, routine screening. You know, the simple Simple stool test, watching for blood in your stool, getting screening colonoscopies, particularly if you've got family history of malignancies, getting upper endoscopy. You got frequent indigestion, someone ought to take a look down there, make sure everything looks okay. Esophageal cancer, gastric cancer, those things can be caught and treated, as can cancers of the colon. The one thing that is easy to take care of is judicious use of nonsteroidals. And I say judicious use, yeah, we all got aches and pains. We all take an occasional ibuprofen or Advil or Aleve or whatever our favorite is. But if you're taking 800 milligrams of Motrin 3 times a day and you're doing it day after day after day, you're going to need a hole in your stomach. And it's just that simple. You are eventually going to get some gastric upset or gastric irritation. Judicious use of alcohol the same way. If particularly if you're taking Motrin and washing it down with beer, eventually your GI tract is going to rebel. For those who are taking Coumadin, monitoring that INR is key and keeping it in the therapeutic range. But the big thing is don't combine aspirin or nonsteroidals or big doses of alcohol. So someone is on Coumadin and they've got their INR at, say, 2.5, where they should be for whatever condition they're being treated for, whether it be PE or DVT or whatever. So they're where they ought to be. They shouldn't be taking aspirin or nonsteroidals because of the risk of stomach irritation. If they get stomach irritation, they're going to bleed, and they're going to bleed quickly. So that's the concern there. And we've gone through, people taking Tums, and then, the miracle drugs of Zantac and Pepcid and cimetidine, all those came along, and now the miracle drugs are proton pump inhibitors, things like Protonix or Prevacid or drugs like that really, each of these drugs works at a different level, but these drugs actually stop the production of acid. And so when someone's got GI bleeding from an ulcerative source, inevitably they end up on a PPI, proton pump inhibitor. So, in summary, GI bleeding can be minor to life-threatening. It can be something as simple as, hey, I saw blood in my stool today. Yeah, you get a rectal exam, you get a stool specimen, yeah, there's a little bit of blood there, there's no blood there. To massive bleeding that requires EMS and requires IVs and requires a trip to the OR. The history dictates where the patient goes. So what they're doing right now and whether they fall into that low risk or high risk category really dictates where they're transported to. Patients with GI bleeds can crash suddenly. They may look fine, but they can get in trouble quickly. And the big thing for us is use protective equipment and prevent an exposure to yourself. If you get spattered with blood, then you're either going to come seeing me or seeing the ER to get a bunch of blood tests and so forth to make sure you don't have an exposure. So that's it. Thank you all for coming tonight. Next month is skills training, as I recall.
Where's it going to be here?
Glenn will send an email. It's going to be one of the fire departments because we're going to do, I think that we're lining up to do airway AED, some things like that. He was putting a list together, so he'll get a list out of where the training will be.